Hi, I'm Katie Crane, and this is the Pilates Lounge. Welcome to Season 4, my friends, of the Pilates Lounge Podcast. This is a space for movement lovers, Pilates educators, and Pilates professionals who want to think a little bit deeper about the work we do. My name's Katie Crane. I've been teaching Pilates for over 20 years, and along the way, I've worn many hats. Studio owner, teacher trainer, mentor, and lifelong student of the work we do. I'm also a surfer, an adventurer, a mum, a busy wife, and someone who believes that movement is by far more than exercise. On this podcast, we talk about Pilates as a practice, not just what we do on the mat or on the equipment, but how Pilates shapes the way we move, teach, lead, and live our lives. We explore anatomy, health, business, culture, and the evolving identity of Pilates in the modern world. This is a place for honest conversations, lived experience, and perspectives that respect both the lineage of Pilates and the people practicing it today. So thank you so much for being here. Let's dive into the episode. So why don't you introduce yourself to our listeners and we'll roll on from there.
Sure. Yeah, so my name's Jack. I'm a physiotherapist based in Melbourne, Australia. I have a clinic along with my business partner, John Nicolosi, called Mad Physiotherapy. So like a lot of physiotherapists, when I graduated back in 2011, two sort of key things: very hands-off, very exercise-focused, and certainly something like fascia was not really something that we discussed much at all. I feel like there was maybe one slide in our anatomy lectures about the muscular fascia, and then you move on from it and never hear it again. And soon after, when I finished physiotherapy, I did a 3-year yoga apprenticeship. So it was during yoga that you'd hear more about fascia, and I'd always wondered, okay, what is this tissue that I never really learn about? We don't really look at it from an anatomical perspective. We don't really talk about its role in the muscular system in regards to movement, force transmission, and if it has a particular role in terms of its innervation and sensory feedback. So I just started trying to read as much as I could about fascia. And that's where I came across a lot of the research from people like Professor Carla Stecco or her brother, Assistant Professor Antonio Stecco, and started to realize, okay, there's a lot more we know about fascia than we're taught at university. Eventually, that led me to fascial manipulation. So that's the method that was developed by their father, Luigi Stecco. And now Carla and Antonio run the Fascial Manipulation Institute in Italy. They're all from Italy themselves. And then I started my deep dive into fascial manipulation. So that originally started with doing their courses. Fascial manipulation is taught over 4 levels. But then for the first time in 2022, they offered an international school program. So this is a 3-year program teaching fascial manipulation that they'd previously taught only in Italian, given again that they're from Italy. But this is an international program that was taught in English. So I applied for that and got accepted and completed that in September last year. So that was a program whereby it was a hybrid format. We did a lot of online learning, but then we would go to the institute in Padua in Italy 3 times a year over 3 years. So I've been to Italy 9 times over the last 3 years, which I know sounds very luxurious, but I can tell you now the novelty of flying from Australia to Italy, that often definitely wears off. And along that journey, back in 2023, I actually got nominated to become a fascial manipulation teacher. So I started that journey back in 2023, of which I finished also last year in 2025. So prior to that, there was a teacher that was coming to Australia once a year to teach the level 1 course. But now I'm obviously very heavily involved in doing a lot of teaching of fascial manipulation, and I'm doing a lot of presenting. So presenting to all the big organizations across Australia, whether that be in physiotherapy, osteopathy, chiropractor, myotherapy, even for remedial massage therapists. And here I am today talking to you.
Sweet. So you want to maybe introduce fascia to our listeners, just because
Sure.
I don't know who's listening out there, but let's go back to the beginning so that people have a clear understanding of it.
So fascia, until really the last 15, 20 years, we didn't really know a lot about what it is. And as a result, when it was discussed, and even to an extent now, often when people talk about fascia, it's very vague or non-specific. Now, you can look at fascia very broadly as looking at the connective tissue system of the body. And so what I mean by that is when you think about looking at an anatomy textbook, or if you've ever been fortunate to be in an anatomy lab, when we look at the body, we think of muscles, bones, ligaments, joint capsules, all being separate tissue structures. So think of like a muscle where you might have something like the quadriceps muscles. Think about the rectus femoris. You think of this clear origin from the front of the hip, inserting down into the quadriceps and by extension the patellar tendon. And we can obviously extend that onto any particular muscle on the body. What we have to realize is that perception of how we look at the human body is very much based on the anatomist. So anatomy, particularly in the last few hundred years, has been based on looking at dissecting away the fascial tissue, because for a long time it was just simply seen as a byproduct of evolution, just simply a bit of cling wrap that wraps around every tissue in the body but has no particular role. And so they dissected away to make this illusion that muscles, ligaments, whatever tissue you want in the body looks like a very separate and independent tissue structure. But in reality, that's an illusion. If you actually maintain and preserve the fascial tissue, you see that it does provide this very interconnected network that in a literal sense does connect everything. But when we think about fascia now, we can start to appreciate that there are different layers of fascia. And this is where I think we're starting to get much more nuance with the conversation of fascia, where we have the deep muscular fascia, which is, I think, what a lot of people think of when you think about the fascial network, the layers of fascia that then help provide an understanding of how the muscular system is continuous. But we also have different layers of fascia, that being the superficial fascia underneath the skin, where we find things like our lymphatic system, our subcutaneous adipose tissue. We find all the cutaneous nerves that innervate the skin. We also have things like our visceral fascia, so the fascia surrounding each individual organ and also providing continuity between different organs in the body. And we also have things like our vascular and neural fascia. So whether that be related to the central nervous system, when you think about things like our meninges, but even within our nerves, within our peripheral body, that things like the paraneural tissue, and then even things like the adventitia that surround our vessels. So when you think about fascial tissue from the micro level, if you're looking under a microscope and seeing each little muscle fiber surrounded by the endomysium, to much more of a macro level when you look at the whole muscle surrounded by the epimysium, or even more broadly, the aponeurotic fascia that surrounds a lot of our muscles and provides essentially like a stocking within our body. In addition to then things like our visceral, our superficial fascia, or even our neurovascular fascia, that there is this continuity and interconnections between the body.
All right. And so does that structure of fascia change depending on whether it's the muscular fascial or aponeural fascia? How does that differ?
Yes, yeah, absolutely. So if we focus on the muscular fascia, so I remember back at university when I was studying physiotherapy, you got that one lecture slide that looks at the cross-sectional area of a muscle. And so if you think about the individual muscle fiber, it's surrounded by the endomysium. If you get a bunch of muscle fibers together to form a fascicle, you have the perimysium. And then surrounding the whole muscle, you have the epimysium. We also have another fascial tissue called the aponeurotic fascia. And this is a fascial tissue that's often forgotten about. So the aponeurotic fascia is different to an aponeurosis. So a lot of the time when people will confuse those two things, an aponeurosis is a flat tendon. So think of in your biceps, you have a tendon that inserts into the radius, but you also have what's called the lacertus fibrosus, this flat tendon sheet, the aponeurosis, which is an example of a aponeurosis itself. The aponeurotic fascia is a tissue layer that sits adjacent to the muscle. So imagine like here's the muscle, we have the overlying epimysium. Then we have the aponeurotic fascia overlaying that. And they are tissue structures that sit separate to each other. But we'll see that there actually are expansions between it. So to give you an example, think of the iliotibial band. So the fascial tissue on the lateral thigh. When we look at an anatomical textbook, you think of the iliotibial band as being this separate tissue structure. But in reality, it's just a thickening of what's called the fascia lata, the aponeurotic fascia that surrounds the thigh. So think about your thigh, think of the quadriceps, hamstrings, adductors. Surrounding the whole compartment of the thigh, we have the aponeurotic fascia called the fascia lata. The iliotibial band is just simply a thickening of that. That fascia lata continues down into the lower leg to form what's called the crural fascia. And then that blends down into the foot to blend into the plantar fascia, which most of us have heard of, and then also the dorsal fascia on the top of the foot. That aponeurotic fascia, essentially like a stocking that covers our whole leg, we find a similar arrangement in our arm. So we have the brachial fascia of the arm that blends into the antebrachial fascia that blends into the palmar and the dorsal fascia of the hand. And then in the trunk, we have different aponeurotic fascia. Through the abdomen, we have the rectus aponeurosis. Through the lower back, we have the thoracolumbar fascia. And the thoracolumbar fascia is an aponeurotic fascia that a lot of people have heard of, because if you dissect away the aponeurotic fascia, you lose the origin and insertion to a lot of muscles. Think of things like the gluteus maximus, latissimus dorsi, the trapezius, serratus posterior inferior, transversus abdominis, to name a few. And if you think about the thoracolumbar fascia, that's a tissue that, because it's so intimately connected to other big muscles in the spine, it helps us to understand that continuity of muscles like the gluteus maximus and the contralateral latissimus dorsi that forms that short spiral that crosses the back, connecting the shoulder and the hip. In reality, though, when you preserve that aponeurotic fascia through the arms and the legs, we can understand and appreciate that there is continuity that extends much further beyond, say, those two muscles. So if we look at, say, the latissimus dorsi and the pectoralis major, we see that it has a lot of what are called myofascial expansions. So essentially expansions of the muscle that blend into the aponeurotic fascia of the upper limb. And similar to when you think about the lower limb, the gluteus maximus, about 80% of its fibers insert into the aponeurotic fascia of the lower leg, specifically the intermuscular septum of the leg, and then even to an extent things like the iliotibial band. So the thing that's often missing when we think about the muscular fascia specifically is that aponeurotic fascia, that tissue structure that sits parallel to the muscle. But even though it sits parallel, we see that there are these expansions of the underlying muscle into the aponeurotic fascia that allow us to appreciate that continuity within muscle and fascial tissue. And there's obviously different models that you'll see that help to understand that continuity of muscle and fascia. I think like one of the most popular ones is things like the anatomy train stuff from Tom Meyer's work. Mm-hmm. In fascial manipulation, what's preserved is that aponeurotic fascia through the arms and the legs that helps us to understand that very intimate connection between muscle and fascia that forms the things like the fascial planes. So that is the continuity of muscles and fascia. But we can also see more complex organizations of muscle and fascia too when we think about the spirals. So if you look at the aponeurotic fascia and the superficial layer, you can see that there is collagen fibers that literally spiral around our arms and legs and then connect the upper limb to the lower limb, crossing the body. And also things like diagonals too, which are fascial layers between the planes.
And so what is fascial's role in the body?
So fascia has a few key roles. Now, one of them is simply just force transmission. So when you think about muscle contraction, again, going back to that oversimplistic idea of looking at the musculoskeletal system, we think of a muscle having this very clear origin and insertion. So when a muscle contracts, it just simply contracts. It transmits forces from the tendon into the bone to create movement. And by no means is that not incorrect. That is true. But in reality, when you start to appreciate the continuity of muscle to surrounding fascial tissue, including the aponeurotic fascia, we see that even from a simple muscle contraction, about 30% of the force is transmitted into that adjacent aponeurotic fascia. And so when it gets transmitted into the aponeurotic fascia, the forces can be transmitted much more globally, whether that be more distally, moving further down the body, more proximally, moving further up the body, but even laterally too. So we can see that there is a lot of force transmission that occurs between different muscles within a compartment. So different muscles that work synergistically. Think about things like the quadriceps muscle, think about the calf complex with the the gastrocnemius and the soleus, we see that there is transmission between muscles as well that helps to distribute forces more broadly. And as a result, when we think about movement isn't just simply about forces being transmitted from the muscle to the tendon. This becomes much more evident when you think about more complex movement. So think about tasks like walking, and even more evident when you think about things like running, jumping, throwing a ball. When we start to do more complex movements, we're moving multiple parts of our body. So think about when you're walking or running, you're coordinating moving your arms with your legs. When you're thinking about jumping, you're thinking about trying to quickly lower the body down and jump off the ground, I should say. When we're doing these more complex movements, the fascial system has a very fundamental role in being able to transmit forces through the body. So when you think about something like running, when we're sprinting as fast as we can, each time we hit the ground, we're putting about 4 to 5 times our body weight through that ground reaction force. And so when you think about that, 4 to 5 times our body weight is a huge amount. Our muscles are not able to tolerate such high magnitudes of forces. And so the way that we are able to tolerate and dissipate those forces through the body is through our connective tissue. So we see that our tendons certainly have a really fundamental role in that. So things like our Achilles tendon is particularly important. But again, thinking about that fascial network from the intramuscular fascia at the level of the endo-periepimysium, but even more broadly through that aponeurotic fascia, it helps us to distribute forces very globally through our body. It also works from the other perspective too. When you think about something like running, when we run, we move our arms. And why do we move our arms? We move our arms to be able to create forces through our upper limbs, and through that fascial network, distribute those forces through our trunk, through our lower limb, to create more forces down into the ground, to create more force output. So our fascial system, when we start to do more complex tasks and when we start to do more higher velocity tasks, it essentially acts more like a spring. And we see this very evident in tendons. So when you think about doing a running or jumping, we see tendons like our Achilles tendons simply act like a spring. They lengthen to absorb that force, and then they shorten to distribute that force back into the ground. And what we see actually when we look at the muscle is the muscle just acts much more isometrically. So it doesn't necessarily change length so much when you're doing running. It just stays isometric as the tendon lengthens and shortens. And our fascial tissue more broadly also does the same thing, to be able to absorb those forces, distribute it more globally through the body, and then also through coordination of our muscles and fascia, distribute that back into the ground to become much more energy efficient. So it has a very fundamental role in force transmission, force dissipation, and also force creation, particularly during high velocity contractions. The other big role that our muscular fascia has, though, too, is we can very much think of fascia as our sensory organ of the body. So think about muscle as the output. Muscle contracts to create movement or to coordinate tension within the fascial network. And fascia is our sensory input. So to understand fascia's role as a sensory organ, we need to understand 2 things. One, it's very, very highly innervated. So our muscular fascia has a lot of free nerve endings that have 2 roles. They have a role in proprioception, so providing sensory feedback to help understand where there is tension in our body. And it has a role as potentially creating pain too. We see that those free nerve endings can create nociception, pain. We also see in particular parts of our fascia, particularly our aponeurotic fascia and what are called our retinaculum. So the retinaculum are thickenings that we find around our joints. So we have retinaculum around our wrists, we have retinaculum in our hands, around our ankles and feet. They're very, very highly innervated in what are called encapsulated mechanoreceptors. So things like Ruffini and Pacini corpuscles. I know some of the listeners might be going, what the hell are those? These little mechanoreceptors called Ruffini and Pacini corpuscles are very highly specialized proprioceptors. So if you look up Ruffini or Pacini corpuscles, you see that proprioception is their role in the body. And so we find these particularly around our joints, because when you think about proprioception, we typically think about joint stabilization and we think about joint positioning. So it's the fascia surrounding the joints that has a really important role in monitoring tension created from movement to provide that feedback to our central nervous system that helps to coordinate muscle contraction. Now, this also brings us to another important point. Fascia is a multi-layered tissue structure. So when you look at the epimysium, so the fascia surrounding a muscle, or again, that aponeurotic fascia, that stocking of fascia that literally almost creates like a jumpsuit, an overall for our body, there are multiple layers. So literally as we move, those different layers of the fascia are gliding on each other. And it's that gliding that's monitoring changes in mechanical tension that then provides feedback to our nervous system to let our brain know where there is tension in the body to help coordinate muscle contraction. So with understanding that, the muscular fascia has a really important role as the sensory organ. I remember once someone describing like this, and I think it illustrates it very well. Think of muscle as fascia speech. So when you think about changes to muscle tone, when you think about changes to muscle coordination, when you think about things like inhibition that can happen from things like chronic low back pain, chronic neck pain, patellofemoral pain, whatever it may be, the changes in the behavior of the muscle are reflective of the changes that are occurring with the mechanical tension in the fascial tissue. And as a result, the sensory feedback it's giving to regulate muscle contraction. So I know I'm throwing a lot out there, but it helps to much better provide the understanding of fascia's role within the muscular system. And fascia is very much our sensory organ. I'll give you a moment there. Do you want to jump in with if you have any questions?
Yeah, no, that's all really great information, Jack. Thank you. So could you explain what does healthy fascia, what does healthy fascia maybe look like, and how does it perform versus fascia that is not healthy?
Yeah, no, it's a important question. So two things we need to think about fascia is there's the layers of fascia I've described, which you'll see described as dense connective tissue. So this is where we find all the collagen. So fascia, the main protein in fascia is collagen. Collagen is the most abundant protein we'll find in our body. And it has the structural properties to be able to distribute forces. So before, when I was talking about force transmission and dissipation, it's collagen that has that role. So if you think about the spectrum of connective tissue, think about tendons. Tendons have a high density of collagen arranged in particularly one direction so that it can transmit forces from the muscle to the tendon to the bone. Fascia we see has also a high amount of collagen, but as I mentioned before, there are different layers of fascia. So one layer of fascia, you'll see that the collagen fibers are in this direction because that particular layer of fascia directs forces in that direction. We'll see that another layer of fascia will alter the direction of forces. And so depending on the particular movement will help us to understand and appreciate what layers of fascia are involved based on whether we're moving forwards, sideways, maybe in a rotational plane, or even a more complex movement where you're moving multiple joints in different directions for things like throwing, as an example. Between those layers of fascia, we have what's called loose connective tissue. Now, loose connective tissue doesn't really have any collagen fibers. It's made up a lot of, predominantly of what are called proteoglycans and glycosaminoglycans. Again, fancy names to describe particular different proteins and molecules in the loose connective tissue. But what we find mainly is hyaluronan or hyaluronic acid. Most people have heard of hyaluronan. It's very popularized in cosmetic products. So you see it for things like rejuvenating skin. And we find hyaluronan abundant at any interface. So we find it really abundant in our joints. And in fact, some people have probably heard of things like hyaluronic acid injections into the joint. We find it really abundant in our eyes to allow our eyes to move very freely. And we find it very abundant within those fascial layers. And the reason why we find it really abundant in those fascial layers is hyaluronan is very hydrophilic. So what that means is it binds to water. And when it binds to water, it creates this lubricant-like substance, this watery lubricant-like substance that allows that gliding to occur in a very frictionless environment. And so ideally, as we move, the layers of fascia are gliding very easily, very smoothly, to make sure that there is no friction. And as a result, it's able to monitor the mechanical tension to provide that normal sensory feedback to regulate normal movement. And at the same time, too, not create too much tension that can then create pain within the fascia. And so when we think about healthy fascia, we're thinking about the dense layers of fascia having good collagen structure, and then the loose connective tissue between being in that lubricant-like state. And this then helps to understand what can change in the fascia. So a lot of the time when people think about changes in fascia, they think about fibrosis or scar tissue. And fibrosis or scar tissue is when you see collagen fibers get laid down in a really disorganized and with a lot of cross links and crossing over. And this will occur very commonly, say, following a significant surgery. So if you've had a big surgical incision, when you cut through the layers of fascia, you can then start to see scar tissue forming. Now, thankfully, this doesn't happen as much nowadays because a lot of surgery is keyhole surgery. They make very small incisions, often following the collagen fibers to minimize the amount of scar tissue. But you still certainly will see scar tissue develop, particularly if it's a big surgical incision. It can also happen from injury. So if you have a really significant fracture, a really large soft tissue strain or sprain, where there's a big disruption of collagen fibers, you can start to see that when the collagen fibers start to come back together, they're a little bit disorganized and form fibrosis. But the other thing that can change in the fascial tissue is at the loose connective tissue, in that watery substance. And in fact, this is where we see changes occur much more quickly and much more frequently. And what can happen is that loose connective tissue can change its viscosity. So what I mean by that is that watery-like substance becomes much more like a glue. And when it becomes more like a glue, that amount of gliding that can occur within those fascial layers becomes much more friction, and it creates a reduction in that gliding. And we can actually see that under things like ultrasound. So if you have an ultrasound over layers of fascia and you get someone to move, we can see that it doesn't really move as much compared to someone who's got normal loose connective tissue where you see that gliding. And that's what's called a densification. So a densification is something that we've really better understood in the last 10 years. And this really comes back to the work of people like Carla and Antonio Stecco. And it's something that occurs very frequently because we can see changes in the loose connective tissue happen very quickly from immobilization or reduced movement. So think about if you've had a broken bone, an ankle sprain, even something like a muscle strain or following surgery. There's a period where you might be immobilized or you certainly don't move that area of the body as much. And so we see that one of the really important things for fascia is we need to maintain gliding really regularly to maintain that healthy loose connective tissue. But if we reduce that gliding or reduce that movement over time, the tissue gets stuck because of a densification. And in reality, a lot of us develop densifications too because of poor posture. We're not moving through large ranges of movement. We might be doing repeated activities that overload the fascial tissue and cause the pH, the acidity of the tissue to lower, which can also form a densification. So movement, minimal inflammation or inflammation that's resolved quickly, so avoiding chronic inflammation, and related to that, making sure that we don't lower the pH are all really important things to maintain a healthy loose connective tissue. And in reality, when we think about fascia, and when we think about fascia causing pain, or when we think about that role of fascia as a sensory organ being disrupted, it happens because of densifications forming that create less gliding and an increase in mechanical tension that can then create pain or affect that sensory signal from the fascia that helps coordinate effective muscle contraction, movement, and transmission of forces through the body.
And what about like aging, Jack? Because if I look at a baby bounces when they fall on the ground compared to an elderly person that doesn't have any bounce at all, how does our fascial structure change as we age? And is that associated with collagen, like the way that our collagen changes, or what's that all about? Hey friend, thanks so much for listening. Did you know that you can now find us on YouTube? at youtube.com/The Pilates Professional. Now, if this episode resonates with you, please share it with someone else who would benefit from hearing it. Back to the show.
So both. So when you think about a baby, in fact, I've got an 8-week-old son myself, so I'm watching his development over time. When you think about a baby, the collagen within their fascial layers is not really well formed. And that's reflective of the fact that their movement is not very good or coordinated as well. If we think about the other end of the spectrum quickly, so in an adult, and particularly the older you get, because of the development of movement from, lifting your head up to pushing yourself up to crawling to walking to running, and then depending on the activities that you do in your life, the collagen that's laid down, whether you've been running your whole life, you've been throwing a ball your whole life, you've been doing sagittal plane running, you've maybe been doing change of direction because you play footy, rugby, whatever it is, lays down the collagen fibers in our body based on where the mechanical forces are applied in the body. As you get older, the collagen tissue starts to become form more cross links. So literally crossing over. So it's almost like it's not necessarily fibrosis, but it's more crossing over that creates more stiffness in the fascial tissue, and it reduces the ability of the forces to be transmitted through a layer of fascia as effectively. So we see that the dense connective tissue changes and becomes more disorganized and more rigid and stiff. We also see a change in the collagen, different types of collagen. So the main types of collagen in our muscular fascia are type 1 and type 3. So type 1 has a lot more stiffness than type 3. And we start to see that as you get older, we see more collagen 1 fibers and also less elastin. So less more of those elastic fibers in it as well. When you look at the loose connective tissue, so that substance between the layers of fascia, we also see that change over time as well. So going back to looking at the loose connective tissue, remember hyaluronan, the main molecule, and it typically binds to water to create that lubricant-like substance. As you get older, we see more hyaluronan within the loose connective tissue. And when I talk about a densification, specifically what happens with a densification is we see hyaluronan start aggregating to itself and not binding to water. So you can actually see this under certain imaging, where you can see a change in the amount of bound versus unbound water. So ideally, we see bound water. It's bound to hyaluronan to create that lubricant-like substance. But in a densification, you see that hyaluronan aggregates to itself and you see unbound water. And when you get older, we see an increase in hyaluronan that predisposes an individual to have more hyaluronan aggregating to itself. And as a result, you see less gliding of fascial tissue. So one of the things that we see as we get older is a change in the dense connective tissue with the cross links forming in the collagen. And we see a change also in the loose connective tissue with an increased abundance in hyaluronan that will change that viscosity and reduce that gliding. And so at the other end of the spectrum, when you think of a newborn, newborns will have those layers of fascia, but the actual collagen fibers are not that well formed yet because we need mechanical forces through our body to lay down collagen fibers based on the particular movement and the direction of forces that are being applied. So in a baby, you'll see really normal gliding, and you can develop densifications within a newborn. I've checked myself in my young one, but the organization of the fascia within the fascial planes takes time to develop. And it's very interesting to note that there is certainly a correlation between the organization of fascia with the development of movement. And so think about with a baby, and as they get older, one of the things that we really develop is an ability to create fine motor control to be able to, say, grasp an object. That's obviously a really fundamental thing about being human, that and obviously then being bipedal. So eventually being able to stand and really be able to coordinate moving our feet, keeping our center of gravity over our base of support, and making sure that we get that effective sensory feedback from our feet to make sure that we know where our lower legs are relative to our trunk. And when we think about that evolution of movement from a newborn to a toddler and then to a child, of course, we see that the fascial tissue becomes more organized. And what we see with that too, and I briefly mentioned this before, we start to see the formation of the retinaculum. So what are the retinaculum? The retinaculum are thickenings of that aponeurotic fascia. So again, think about that sleeve of fascial tissue. Around our joints, we see the aponeurotic fascia thicken to form the retinaculum. And that's where we find those really specialized proprioceptors, that's Ruffini and Pacini corpuscles. So as the retinaculum forms, it allows us to create the much more complex and nuanced movements and be able to do things like opposition and grasp objects, to be able to manipulate the physical world with our hands. And then also when we think about the retinaculum of the feet and the ankles, the ability to be able to effectively coordinate and position our feet to make sure that we can walk effectively and move our body through the physical world as well. So that sort of describes that spectrum from newborn to elderly. Changes definitely happen within the dense and the loose connective tissue. And as we get older, one of the things that we're predisposed to is the fascia becoming much more stiff, and we see less gliding over time too, which certainly can be something that's contributed to things like changes in our balance, which is obviously really important in older adults, changes in potential more predisposition to pain from the fascial tissue. And then, as you mentioned before, when you're thinking about how we can see changes in the stiffness and rigidity in our body, or the ability to be able to absorb forces as we get older, because we lose that elasticity to be able to use our fascia like a spring, to be able to transmit and dissipate those forces more globally, which becomes more compromised over time. And that sort of helps us to understand too fascia's role in making sure that we minimize high peak concentration forces in our joints, because obviously as we get older, one of the things that we're predisposed to is things like osteoarthritis or just degeneration in our joints overall. And if we lose that ability to be able to dissipate forces within our fascial tissue, that means that we're going to see higher peak concentration of forces in our joints as well. And it's interesting to note that there's been some interesting research from the Stecco group, specifically Katerina Feder is one of the researchers who works closely with Carla. They've done some interesting research of looking at the association between changes within, say, our hip joint with things like degeneration or osteoarthritis, and increases in stiffness and rigidity within our iliotibial band. And in fact, we see that those two are very correlated. So an increase in degeneration, an increase in stiffness of the IT band. Now, it's just an association study, an observational study, so we don't know really cause or effect, but we certainly see a correlation between the two. In reality, it's most likely the fascial tissue that becomes stiffer first, because the fascia can change its stiffness much more quickly than the joint can degenerate. But that's just purely, my opinion. We don't really have the evidence to highlight that it's that direction that occurs.
And so with that in mind, say I'm working with, let's take, for example, somebody with that, a hip issue, and we can see that they're getting really stiff through that ITB. Is the best thing for us to do, to try and encourage better movement in that whole system? And if so, because from what I see, say if I'm working with somebody, they've got a sore hip, they're starting to walk like a penguin, so it looks like, okay, they're potentially headed down the road of a hip replacement and they're elderly. What's actually happening in the body when that's happening? Like, why is their whole posture changing so much, when as they're dealing with more and more pain? Like, is it the degeneration that is causing those postural changes? Is it the thickening of the fascia, or the changing structure of the fascia? Is it the dehydration because of they're not moving? I'm assuming that it's all and above, isn't it?
Yeah, look, absolutely. Look, there's I look at it as a sequelae of events. And when you think about, say, degeneration of a joint or OA, it's not something that happens overnight, unless there's obviously, say, a significant trauma or like an infection. But in reality, for most people who experience osteoarthritis, it's something that develops over time, very slowly. And so ultimately, that's a reflection of a couple of things. One, changes in the arthrokinematics of the joint, so how the joint moves. We also know that osteoarthritis is very much a systemic problem. So it's not just simply related to the musculoskeletal system, but overall systemic health and well-being. It's ultimately a low-grade chronic inflammatory state. We know it has a high association with things like metabolic syndrome. And because of that change in our inflammatory profile, it can also start to cause catabolism, breaking down of the joint tissue. But when we think about the myofascial system and the articular system, there's definitely a real overlap. Now, when someone starts to create an antalgic gait pattern, so changes in their movement, and let's say we know that some of it is coming from the joint at least, it's multi-layered, because certainly you can see changes in how someone moves and how someone improves their overall function by trying to address and improve the myofascial system. So that could be things like looking at trying to improve flexibility or myofascial compliance by improving their strength in particular, to be able to help shift, reducing some of the peak forces in their articular system and increase the ability for the myofascial system to be able to distribute those forces more globally and minimize that peak force within the joint tissue. But what do we need to do to actually effectively do that? Well, I definitely think part of it is about improving things like strength, because the more we can create force within our muscular system, the more we can also then use our muscular system to distribute forces through our fascial tissue. I'm also a very big advocate for things like stretching. I mean, I have a background in yoga myself, and I certainly see that there is an ability to improve movement and, again, minimize forces through, say, our joints, and using this example, by improving that elasticity or compliance. The other thing that I do a lot of too, and this is certainly a fundamental element of fascial manipulation, is thinking about how we can improve fascial gliding through hands-on treatment. So when we think about hands-on treatment, there's obviously a spectrum of different types of treatment we can do. And we can think about things like intensity. We can think about things like depth, because that will obviously influence the layer of tissue we're working at. And if we think about just heat in general, heat can improve gliding of fascial layers. But heat alone, although it can cause a change in the loose connective tissue, when the tissue cools down, it becomes densified again. So one of the fundamental things to help alter the loose connective tissue is things like friction. And the reason why friction has a really fundamental role in changing the loose connective tissue is that sheer mechanical force can alter the chemical structure of the loose connective tissue. And this is obviously going a bit more into looking at fascial manipulation specifically, but something I obviously use a lot of, is trying to identify where densifications are in the body, because we find that densifications often tend to be in very specific spots in the body, and densifications over time beget densifications, so they spread. So we can see that densifications will form within a particular pattern, often through like a fascial plane, or could be a spiral or a diagonal, as we talk about in fascial manipulation. And that helps us to understand that we can see that a densification that doesn't just simply just form within a symptomatic area. So, if you've got, say, hip pain, it doesn't just simply form around the hip. We can see that densifications can form much more globally in the body. And certainly when you restore the fascial mechanics by identifying where those densifications are and restoring that gliding, that's when you can also see very significant improvements, very acutely too, within movement. And the reason being is when you restore that gliding, it can reduce the element of pain that's generated from the fascial tissue, because even with things like osteoarthritis, there's often layers to what generates their pain, from the articular system to the myofascial system. So we see that reduction in pain. We can also see an improvement in gliding that helps them transmit forces more effectively through the fascial tissue, that then again reduces those peak forces in the joint tissue. And also we can see improvements in the sensory feedback that the fascial system provides that helps to better coordinate and recruit muscle, so that we're making sure that muscle is effectively contracting to help stabilize a joint, but also to help coordinate where tension's created in the fascial system, to again thinking about distributing those forces more broadly in the whole myofascial network. And it's interesting to note, like when you think about something like osteoarthritis, and you look at, say, radiological investigation, so whether that be things like an X-ray, a CT scan, an MRI, there is a correlation between the degeneration you see in a joint and the severity of symptoms and individual experiences, but that correlation isn't perfect. So what I mean by that is there are some people who may not have, like who may be in their 60s, 70s, 80s, so in an older population group who are more predisposed to osteoarthritis, who may have, for instance, no pain in their hip whatsoever. But when you take a scan of their hip, we actually can see quite significant degenerative changes to the hip, yet they experience no pain. At the other end of the spectrum, we can also see that some people might experience a lot of hip pain that's very indicative of, say, hip osteoarthritis. And when you look at their scan, the amount of degeneration in the joint actually isn't that significant. And there's obviously the whole spectrum in between. So that makes you think, well, why is there not a perfect correlation between degeneration in a joint and symptoms? There's a couple of reasons. One of them I certainly think is related to overall systemic health, like I mentioned before, because we know that osteoarthritis is not just simply a wear and tear disease of the musculoskeletal system. We know that other non-musculoskeletal factors, things like your metabolic health, things like your inflammatory status, will have a big indication of whether you're symptomatic or not symptomatic. But I think the other area that's often underappreciated is the health and the function of the myofascial system, and how that can help to distribute forces more broadly and reduce the peak forces within the articular system. And there's a lot of things that we need to consider with how we improve that, whether that be related to things like improving strength, improving compliance, and then certainly when we think about the potential value of how we can identify these densifications and restore them to make sure that there is effective gliding of the fascial tissue.
So when you practice your myofascial manipulation, what does that look like?
So fascial manipulation is very much an assessment framework as it is a treatment. I think a lot of the time when we think about different techniques, whether it be like fascial methods, a lot of people think about different treatment techniques. Now, in fascial manipulation, we talk about different layers of fascia. We've obviously focused on the muscular fascia, but there are things like the superficial, the visceral fascia, and also, again, the neurovascular fascia. Now, when we think about the musculoskeletal system, we are thinking about looking at the body as a whole. We're thinking about what someone's presenting with in terms of where are their symptoms, and they might have multiple locations. We're also thinking about the individual story of the patient who's presenting in front of you, because whether it be hip pain, whether it be back pain, whether it be neck pain, these are conditions that we see frequently within the general population. But when you think at an individual level, each individual has a different past medical history, a different story. So you might have 5 people presenting with low back pain that we see a very similar pattern. They may have had it for many years. They may get aggravating factors that are very similar. They may experience the pain symptoms in similar locations within the lower back. But each individual has a slightly different history in terms of what preceded the onset of their back pain. Because a lot of back pain, a lot of hip pain, a lot of neck pain, it's often very much an insidious or a gradual onset. There obviously are situations where someone develops back pain following, say, a motor vehicle accident, where they may have, say, fractured a vertebral body or a spinous process. But for a lot of us, they develop pain much more gradually. A lot of people you talk to, I've had back pain for 10 years. Was there any particular trauma associated with it? No, actually, I just started developing it over time. I noticed it bending forward and I haven't been able to get better since. But the thing that we see that varies from person to person is, well, what is it in your past medical history that may give us clues of where there may be changes within your fascial gliding, your fascial mechanics, that's contributing to your low back pain or hip pain? And when you think about it, some people may have had recurrent ankle sprains. Some people may have fractured their shin. They may have had an ACL reconstruction. Maybe they've had a total hip joint replacement. Maybe they've had recurrent shoulder dislocations. The list of musculoskeletal injuries can be very extensive and will vary person to person. So when you take a step back, those old injuries where we've had a broken bone and we've been immobilized, where we've had an ankle sprain, where we've had reduced range of movement and inflammation, where you've had an ACL reconstruction, and from the surgery, again, you've been immobilized, you've had incisions into the fascial tissue. These are all things that can alter that fascial gliding and can cause densifications locally where that old injury is, whether that be down the lower limb, in the arm, wherever that may be. And so when you think about the concept of densifications, that lack of gliding reduces not only gliding within the fascial tissue in that area, but over time, it can start to create densifications above or below, depending on where the injury is, because that lack of gliding through your forearm, as an example, from an old wrist fracture, means that even once the wrist fracture's healed and you can move your wrist, at the layer of the fascia, it can still be stuck, it can still be densified. And that densification can spread because that lack of gliding through the forearm starts to affect the lack of gliding through the upper arm, in the shoulder, and then it can start to affect the amount of mechanical tension in the neck. So that old wrist injury, as using this example, that feels fine now, doesn't really cause us any issues. Maybe there's some issues. Maybe you feel like the wrist is a bit stiff. Maybe when you put weight through it, it feels like you're getting a bit of a pinching sensation. But overall, you don't really think about the wrist. That has created changes in that gliding through a particular fascial plane or a particular fascial line that's now affecting the fascial mechanics at the neck. And now that person's presenting with neck pain because all of a sudden when they turn their head, they're starting to experience pain within their neck. The same can be applied when you think about the lower back, as I gave the example before. All of a sudden you're experiencing pain on the one side of your back bending forward. You've had it for years, but there's no particular trauma. It could be related to the hip, and it even could be related to something like osteoarthritis, where although we can't necessarily cure the osteoarthritis itself, we can identify that old fibular fracture in your leg has created a lot of rigidity through the lateral sequence within the fascial sequence of the leg that's affecting the tension within the crural fascia down low through the iliotibial band, and now is affecting the mechanics of how your joints are moving or creating a higher concentration of forces within the hip joint. So fascial manipulation is very much a systematic framework to look at assessing changes that can happen within the fascial tissue, but also really trying to connect the dots, thinking about what is it about this individual, whether they're presenting with hip pain, back pain, neck pain, ultimately any particular type of musculoskeletal pain. Is there something in their past medical history that can give us clues to look at, you know what, I actually need to look at their lower leg because they had that old fracture before they started getting hip symptoms. Or I need to have a look at your knee because of that old ACL reconstruction that happened prior to you developing back pain. Or I need to have a look at your wrist, using that example before of that old wrist fracture that developed prior to you developing neck pain. Because ultimately, when we think about the fascial system, it provides an anatomical framework for understanding how the body is connected. And by understanding those anatomical connections, we can appreciate that when we start developing pain in a certain area, we can see a contribution of the fascia because of changes in fascial gliding, not only locally where the symptoms are, but thinking about where the origin or the root cause of the problem is. Because particularly in the presence of developing pain that's more of a gradual onset or isn't necessarily associated with a specific or clear trauma within that area, we need to be thinking about, well, what is it that's contributing to this presentation? And certainly there can be many things to that, but the fascial system helps us to understand how there are connections in the body, and that from old injuries that may seem like they're okay now, because a lot of the time that old wrist fracture is okay, that old ankle sprain you don't have any issues with now, but there can be remnants of changes in fascial tension that are contributing to symptoms elsewhere in the body.
Yeah, that's really cool. I feel like that's, I mean, you practice yoga as well. In Pilates, we are always looking, you come to us with a hip pain or whatever, but we're always looking up the line and down the line to see, okay, well, how is that relating to the way that you move in your whole system in general? And that's where the magic happens in Pilates, right? Is from the whole body moving.
Absolutely. The way I look at it is, and this is getting into a bit more of a thinking about and it's more of a how we look at the human body. And the problem that we have when we think about how we assess the human body is we need to understand that it is what we call a complex adaptive system. So complex in that we have multiple different systems or multiple different parts that are interacting with each other. So when we think about someone presenting with hip pain, back pain, you're only limiting yourself to getting potential short-term improvements by only looking at the local tissue mechanics. We need to think much more broadly about how the body is interconnected by understanding how it is from an anatomical perspective, but even when you think about how the human body works as an interconnected system. The other thing too is whenever someone develops pain, again, whether it be hip pain, back pain, absolutely you'll be able to find changes locally. We'll see changes potentially in the fascial mechanics. We'll see changes in muscle tone. We'll see changes in muscle activity. So these are all things that we might identify and go, all right, you've got hip pain, we're palpating around, we've identified these problems, we're going to give you exercises for the hip. And certainly you may see some improvements of that related to that. But the thing we need to consider is, are those changes locally where there's symptoms? Are they the proximate or are they the ultimate cause? And what I mean by that is it the secondary or is it the primary problem? Because we know that whenever you experience pain, that there's going to be changes locally within how the joint moves, within how the muscles contract, within the muscle tone, to give some basic examples. And we can treat those, but what happens if they come back? And a lot of the time they will come back because if you're not looking at the body more globally and thinking about where the root cause of the problem is, that you haven't restored the whole system. And so ultimately, and there's obviously different frameworks we look at that, but with fascial manipulation, we're trying to think about creating a hypothesis to go, well, okay, I know I'm going to see some changes locally. I may need to do some treatment locally, but if I just treat locally, am I going to see a long-term effect? And I know for me personally, that was something that I found a lot of frustration with just thinking about trying to treat the symptoms locally, because ultimately a lot of the time you are just treating the symptoms, you're not treating the cause. So we need to develop a broader framework of how we look at the body as an interconnected interconnected system. And in that we can see that there is organization, because certainly we can use, going back to the beginning of this conversation, yes, we can say that fascia is connected and connects every part of the body. That's true. But there is organization in that. And we can find organization where we see changes within a particular fascial sequence or plane or spiral. And it helps us to understand current symptoms and prior injuries and how prior injuries may contribute to alterations in the fascial mechanics away from the symptomatic area.
This is all such great information. I've got one more question. I've got to wrap up in a second, but I've got one more question. Does fascia have memory? Like, so for example, I work with a guy who was a professional squash player, and he would come in and he would be like so wound up, like literally walk in the door like his body is so torqued in one direction from always playing so much squash. And we would spend the whole session unwinding him, and he'd walk out relatively straight again and feeling better, because he would get really sore being so wound up. But then that unwind wouldn't last for the whole week. He would kite surf and wakeboard and do all these other things, which were really dynamic exercises, but not in the same wind up as what squash was. But he'd every week come back wound up as if he's played 10 rounds of squash. Does fascia have memory, or what's happening there?
So, I mean, it definitely has. We can look at this in few different ways. When we think about the muscular fascia, let's start there. It certainly has memory, because when you think about the laydown of collagen, that's based on the mechanical forces applied to it. So your fascial system, in terms of the muscular fascia, is going to be organized, and it's going to have more density or more fibers oriented in one particular direction based on you as an individual. And that's related to your past history in terms of what you've done physically, in terms of sport, how you move, in terms of the particular patterns of how you coordinate movement in your human body, There are other factors too, like we see differences in males versus females based on hormonal profiles as a factor. Even like things too, when you think about old infections and things like that, that can potentially create changes in the fascial laydown and mechanics. So when you think about memory, I mean, a lot of the time when we think about the musculoskeletal system, people talk about muscle memory. I think it's actually much more fascial memory, because ultimately it's the fascial tissue that gets reorganized based on your particular movement patterns, your particular sports, your particular injuries that you've developed. Now, there's probably a bit more of a broad philosophical question to be had too about memory when you think about changes in the fascial tissue from maybe like non-physical factors too. So that could be related to maybe internal dysfunctions. So when you think about people who experience digestive issues, issues with their reproductive system, issues with their respiratory fascia, whatever it may be, of how that can change the visceral internal fascia, that can also then has very intimate connections to our muscular fascia as well. And that can certainly affect things like how we move, things like posture as well. And certainly we know that when you think about recurrent issues that people experience where they might have some liver dysfunction, whether that be things like cirrhosis as an example, we know that the fascia surrounding the liver becomes much more thicker and fibrotic. And that's correlated to the state of the health of the organ and to the particular pathology, if it's something like cirrhosis. And we have to appreciate that our visceral fascia is literally suspended within our muscular fascia. So when we start to see changes in the rigidity or the stiffness of our visceral fascia, that can alter the mechanical tension created on the muscular fascia and affect our posture as well. The other element then is the superficial fascia. So the superficial fascia is the fascia that's underneath our skin. And we know that the superficial fascia has particular roles. So we find our lymphatic vessels in our superficial fascia and our lymph nodes. We do find some in the deep fascia too. We see the subcutaneous adipose tissue. We see our cutaneous nerves. But we also know that the superficial fascia is intimately connected to our autonomic nervous system. It provides all the sensory feedback of the outside world to our autonomic nervous system to regulate things like our immune system, our metabolism, things like our thermoregulation when you think about changes in temperature. And so when I think about the superficial fascia and its relationship to the autonomic nervous system, it also makes you think about what other things can affect your autonomic nervous system. So I'm talking about things like stress. So again, this is more of a anecdotal thing and theoretical, but it does help us to understand a potential link between our psychological or our emotional state to the fascia through the superficial fascia at least. So when you think about movement and when you think about even if you provide an effective therapy to restore fascial mechanics and improve someone's movement, if it's something that continues to come back, there's a couple of things to consider. Is one, have you restored the fascial mechanics globally through the body, particularly when you think about the muscular fascia and thinking about old injuries? But then you also have to consider too that there may be changes in how someone moves, or even related to the pain generated because it changes to other layers of fascia, be that things like the visceral or the superficial fascia. And there are ways that we can assess and treat that. But ultimately too, even if someone, for instance, has a digestive issue, as an example, where they have irritable bowel or they get constant bloating, constipation because of a food intolerance, you may be able to help improve their movement. But if they keep getting that recurrence of irritation to their gut because of the food that they eat, you can do all the right treatment you want to help improve the visceral fascia and the muscular fascia. But if you still got that insulting factor that's causing the rigidities to redevelop, you're going to have potentially a short-term effect.
All right, that's all such fascinating information. So if people do want to learn more about fascia, because fascia is, I feel like for us as movement educators, it's to understand fascia better can really be a missing link. Like we learn basic anatomy when we start teaching Pilates. we learn muscles and joints and ligaments and bones, which is a really important foundation of our knowledge. But I feel like if we can understand fascia better, then we can actually understand the why behind what we're doing, and actually what's happening in what we're seeing is happening in the body, right? So if somebody wants to learn a little bit more, where do you think is a good place for them to start?
Well, look, there's a few different ways you can approach it. I mean, certainly look at the research published by people like Carla Stecco, Antonio Stecco, and some of the colleagues they work with, people like Caterina Fede, Carmelo Piri, and they certainly collaborate with other researchers around the world. Look, I certainly do a lot of presenting myself. I can actually share with you, and you feel free to share it with your listeners. I recently did a free webinar talking about the scientific foundations of fascial manipulation. So that's really looking at some of the anatomy, the biomechanics, the role of fascia as a sensory organ. And I do a lot of webinars throughout the year as well. So these are just free to anyone who wants to join in and listen. I also do workshops and courses too. So I'm teaching fascial manipulation. I teach the level 1 course regularly throughout the year, mainly in Melbourne. I'm also teaching a course in Sydney. I also do introductory workshops. So these are just 1-day workshops to really give people an opportunity to look into what fascial manipulation is. So these are more very much introductions to help dip your toes and learn a bit more about the science behind it, but some of the clinical application. And I'm actually doing a bunch of these around Australia this year. So I did one in Melbourne earlier this year. I'll be doing some more in Melbourne later in the year, but I'm doing one in Brisbane, Canberra, Adelaide, Perth, Hobart throughout the year. So if people do want more information of that, I can obviously share my details with you. You'll find more about me. If you look up Jack Williams Fascia, I should come up anyway, but our website, Melbourne Athlete Development, that's information there that you'll find about the courses and the workshops too. So you'll see that there's a link there to professional development courses and fascial manipulation. So through that, you'll find information about the workshops and the courses. You can sign up to my mailing list. So I can then keep contact with you with things like the webinars. I'll be doing more webinars throughout the year. And obviously, I'm very happy to share any other resources I have, whether that be related to specific research if people want some help reading certain content, or any other recommendations. There's a lot of textbooks out there as well that Carlos and Antonio and Luigi Stecco, the founder, have published related to the method, related to fascial anatomy. So there's a lot of good information out there.
Okay, that's amazing, Jack. I really appreciate that. Because I feel like we really only scratched the surface, right? In a 1-hour conversation. There's so many ways that we could go, but the whole point of this really is just to start to pique other people's interest in the information that is available for us, so that we can continue learning as Pilates professionals. So thank you so much for joining us, Jack. I really appreciate it, and we will definitely share all of your information. Just make sure you fill out that in that info form for Nisa, for the podcast producer, and she will share any information that you want to share there. She'll put it in the show notes for us.
Great. Thank you very much, Katie.
Awesome. Thanks, guys. Thanks for joining. We'll see you next week on another episode of the Pilates Lounge podcast. And that's a wrap, my friend. Now, before you go, make sure you check out the show notes. That's exactly where you'll find anything we're offering alongside this very episode, and the link to subscribe to the Pilates Muse newsletter. Our subscribers receive free handouts and resources connected to the topics we explore right here. They're specifically created for Pilates professionals, movement educators, and Pilates lovers just like you. So until the next episode,